Assalamu alaikum. Good morning, good afternoon, and good evening. Welcome to our Ifso webinar. It's been a real pleasure to welcome you here to an exciting webinar, which I'd expect to draw a lot of discussion, a lot of engagement, and we look forward to welcoming you all. My name is Hazem Al-Momani, a consultant surgeon working in Abu Dhabi, the United Arab Emirates. And today I am humbled to be joined by esteemed colleagues from around the globe. Our dear speaker, Dr. Sarah Suleiman. Dr. Sarah Suleiman joins us from Imperial College London, Abu Dhabi. She's a consultant endocrinologist, diabetologist, and a bariatric physician. She's the lead clinician for obesity and metabolic surgery and the lead clinician for genetic of diabetes and endocrinology at Imperial College London. Dr. Suleiman also is an honorary senior lecturer at Imperial College London. All the way from the US, I would like to welcome our dear colleague, Professor Donna. Donna Ryan joins us from Louisiana, USA, from Pennington Biomedical Research Center. I also would like to welcome for the first time on our platform, Dr. Iba Al-Azeri. Dr. Iba, welcome. She joins us from Kuwait. Dr. Iba is the Chief Medical Officer of Dasman Diabetes Institute, Kuwait. I also would like to welcome my dear colleague from Lahore, Pakistan, Dr. Tahir Yunus. Dr. Tahir has got experience in having practiced in the US, Saudi Arabia, and recently relocated to Pakistan. Dr. Tahir is a consultant bariatric surgeon. He's the director of the ALSA, Pakistan Center for Advanced Laparoscopic and Bariatric Surgery at Evercare Hospital, Lahore, Pakistan. And last but not least, I'd like to welcome my dear brother, Dr. Bassem Safadi. Dr. Bassem is a well-known and respected colleague of ours who's practiced in Lebanon and currently is based in Qatar. He's the chair of the surgical services at Amman Hospital, Doha, Qatar. Our topic today is a bit of an unusual topic to be discussed on a surgical organization institute, where we'll be talking about the new pharmacotherapies. The last couple of months have witnessed new developments, new publications, new advancements in the topic of anti-obesity medications. Dr. Suleiman will be shedding a lot of light about this topic to talk about the recent updates, the recent evidence, the current practice, and how would this impact our management for such a complex and chronic disease, i.e. obesity. Dr. Bassem and Dr. Tahir, I'd anticipate them to be defending our corner as surgeons to see how we can keep our practice afloat. It'll be a very heated discussion, medical versus surgical, girls versus boys. Let's see how it goes. Without further delay, I'd leave the floor to Dr. Sarah Suleiman. The floor is yours, Dr. Sarah.
Thank you very much, Dr. Hazem, for the invitation, the very kind introduction, and the challenge. I look forward to taking this on. So I have no conflict of interest. Just to remind everyone that obesity is a chronic, relapsing, multifactorial neurobehavioral disease. So it is not something that you have one treatment for and it goes away. This is a lifelong treatment. It results in excess body fat, which promotes adipose tissue dysfunction and abnormalities in metabolic, biochemical, and psychological health consequences. What I'd like to do is briefly, I don't need to remind this audience about obesity and why it's important to treat it, but we'll go through it briefly. We'll speak about the classification and staging of obesity, what the management framework looks like now, about older oral anti-obesity medications, GLP-1 agonists, which are the mainstay of medical therapy now, and neuroagents. And I've got one slide on the impact on the future of bariatric or metabolic surgery. Hopefully it won't be doom and gloom. So as we discussed, there are many disorders associated with obesity, diabetes, high blood pressure, cardiovascular disease, non-alcoholic fatty liver disease, as well as some mechanical disorders, cancers. It really is a problem. So if we look, excuse me, but it isn't doom and gloom because it is a reversible condition or a treatable condition whereby loss of even a small amount of weight, so 5% or thereabouts, can improve glycemic control and hypertension. More than 15% can actually result in type 2 diabetes remission, reduced cardiovascular mortality, improvement in heart failure, and everything in the middle you can see. Just looking at a few examples, and this is one that remains very pertinent, comparing someone with a body mass index of over 35 to someone with a body mass index of 22, they are 100 times more likely to get type 2 diabetes. We know from the SOS that there is improvement and remission in diabetes even 15 years out. Although there is a reduction, possibly related to weight regain, they still remain 6 times more likely to be in diabetes remission. And from the STAMPEDE study, we were educated that even those on insulin, so if you look at the left column in the red box, about half of people at the start of the study were on insulin and only 12% at the end with a gastric bypass, and really not different with a sleeve gastrectomy. So bariatric surgery does work for diabetes reversal. We've learned more recently that actually even very low calorie diets work. And this is the direct study. And we can see that about 50% of people reverse their diabetes in the first year. And if you split it into weight lost, those who've lost over 15 kilograms, 86% had diabetes remission just with a very low calorie diet in the first year. And this was reduced to about 70% in the next year. Another disorder associated with obesity is fatty liver disease, which was associated with cirrhosis and liver cancer. It's the new kid on the block. And again, with a 4-week very low calorie diet, liver fat reduced from 36% to 2%. So losing weight is good for us. Cardiovascular mortality, which is the holy grail, increases significantly after a BMI of, again, around 35. And Ali Aminian and colleagues have very nicely shown us that there is a reduction of about 40% in cardiovascular mortality, so equivalent to statin therapy following metabolic surgery. Obesity is associated with many types of cancers. These are the 13 most often seen. However, only 35% of cancer survivors are obese. And this is because obese individuals generally have worse screening. Treatment doesn't work so well at higher weights. Their survivorship is reduced. And if you look at absolute numbers, there's a 50% increased risk of death in obese men who have cancer and 60% in women. Again, if we look at the Swedish obesity study, bariatric surgery, certainly in women, reduces that risk. And this is my final slide on risks associated with obesity, and one of my favorites. In renal failure, so proteinuria, rather than advanced renal failure, mortality rates are increased. And the 5-year mortality rate is reduced by 2/3 in those who've had bariatric surgery. So we've moved away from using just BMI as a marker of obesity because it doesn't tell us if this person has renal failure, diabetes, sleep apnea, or other functional things. We tend to use obesity staging systems, one of which is the Edmonton Obesity Staging System, which goes from stage 0 to stage 4, according to severity of medical, mental, and functional disorders. So how would we manage obesity? Metabolic or bariatric surgery is still the most effective long-term management strategy for obesity, and we're all indebted to SOS. Every single one of us has used this slide to show that over 20 years, those who've had gastric bypass have had more significant weight loss than those who've had vertical sleeve gastroplasty or banding. And compared to controls, there is significant weight loss from all 3 groups. If we look at a review on the reduction or improvements with bariatric or metabolic surgery, absolute all-cause mortality is reduced by about 40%. Cardiovascular disease is reduced by 56%, cancer by 2/3, and diabetes by 90%. Bariatric surgery, I believe, is a proof of concept, which tells us that weight loss, especially 10 to 15%, has great health benefits. However, it should not be the only answer for obesity management. And weight regain post-bariatric surgery is the bane of most of our lives. Just to put things into perspective, there are more than 1 billion persons living with obesity worldwide. And at the moment, 0.0001% can get bariatric surgery. So as opposed to the old model where it was diet and exercise, lifestyle, pharmacotherapy, surgery, we now use a model where all of us come in at the same time, and those who have more severe obesity with maybe stage 3 or 4 Edmonton staging might be offered bariatric surgery first off, or medication and bariatric surgery, very low calorie diets. So going into medication, the history of medical therapies for obesity is dire. For many years, many medications came in and had to be withdrawn due to hyperthermia, sudden death, valve disease, psychiatric disorders. More recently, however, we've been slightly spoiled for choice. So over the last few years, we've had a few medications. I'll discuss those that are available, and we'll move on to newer ones. And just to give you a heads up, obesity is a brain condition. It's a brain disease, and that's why most medication for obesity work in the brain. So if I just choose my pen. The ones in red are those that are available in the UAE. So Contrave is a combination of bupropion and naltrexone. I'll speak about these in a minute. Bupropion alone, or Zyban, is used for cigarette withdrawal or addiction, and topramate is used mainly for migraines and by some psychiatrists, but both of them are very efficient in reducing weight. Leptin and setmelanotide work for people with monogenic diseases, so a single gene causes the obesity. Once it's found, it's a genetic condition, so these are patient-specific disorders. GLP-1 agonists are the mainstay of our treatment, and we'll speak about that. Metformin is an anti-diabetic medication. 10% of people lose more than 10% of weight on it, so it's worth a try. It's cheap. It has minimal side effects. Orlistat is one of the very few that works on the gut alone. It doesn't allow the absorption of fat, and we'll speak about them again. So orlistat is a pancreatic lipase inhibitor. It's one of the older anti-obesity medications. It malabsorbs about 1/3 of fats, and therefore they come out in the stool. In people who have a very high diet, they are troubled by soiling and diarrhea. The weight loss in the UAE really isn't great. So it's reported that the weight loss is about 5%, but we see about 2 to 3 kilograms weight loss. The dosage is with each meal, and the main side effects, as expected, are diarrhea, oily spotting, and flatulence. Okay, Smea is not available in the UAE. It's a combination of phentermine, which is a sympathomimetic appetite suppressant, and topramate, which is a neurostabilizer. Nobody quite knows how it works, but it suppresses appetite. It was initially used for epilepsy and migraines and still is used for these. It's licensed for long-term treatment. In the older generation drugs, it's one of the better ones with 6 to 11% weight loss. 70% of people achieve the 5% weight loss, which anti-obesity medication licensed, and about 50% lose 10%, with the associated benefits in blood pressure, lipids, and HbA1c. It has a very slow build-up, so you increase the dose every 15 days. And similarly, if you want to withdraw it, you need to reduce it alternate days to avoid seizures. It can make people drowsy, should not be taken with alcohol or drugs, can cause acute glaucoma. All anti-obesity medications are not safe in pregnancy, and this is not an exception. And all anti-obesity medications, apart from orlistat, can be associated with suicidal thoughts. So just a heads up, I'm not going to be saying this all the time. Lorcaserin is a selective 2C receptor serotonin agonist, which activates the satiety pathway, so makes people feel full, with a weight loss of about 4%. compared to placebo, it looks as though they had a very good lifestyle program there, because with placebo, there's about a 4% weight loss as well. It's twice a day dosage. And with all anti-obesity medication, once you have achieved the target dose for 3 months, if there is no weight loss, it is suggested that you stop and change to another one. The main side effects are serotonin induced side effects such as flushing, tachycardia, headache, or dizziness. It can also cause a dry mouth and constipation. So about 50% of people lost 5%, and about 25% of people lost 10% of their body weight. Contrave is available in the UAE, and again, it is a combination of naltrexone, which is used to treat drug and alcohol dependence, as well as bupropion or Zyban, which is used for cigarette addiction. The mean adjusted body weight loss is about 4%. Studies have been completed in children, and we're waiting for the results of that, and that is available in the UAE. It comes as a combination tablet, and you start with 1 tablet, then 2 in the morning, 1 in the evening, as you can see on the top right. The main side effects are GI side effects with dry mouth, nausea, vomiting. However, again, it can cause suicidal thoughts and has been associated with serious neuropsychiatric events. It's to be avoided in people with hypertension, recent heart attacks, seizures, renal failure, and pregnancy. This is one of my favorite drugs, even though I have never used it. So this is actually licensed as a medical device at the moment by the FDA. It's an oral hydrogel, which once it hits the stomach acid, then expands and fills the stomach, giving a feeling of satiety. The mean weight loss is about 6%, but about a quarter of people lose more than 10% of their weight. And certainly thinking of children and adolescents, this, I think, would be a relatively safe option. Now we come to the bulk of the talk, GLP-1 receptor agonists. They've been around for almost 2 decades now. They are hormones that are produced by the gut, but act in different areas of the body, mainly the brain, increasing satiety and reducing appetite. They work in the liver, reducing inflammation and insulin resistance. They result in weight loss and reduced visceral fat. And more recently, they've been associated with many things, as you can see on the right. Improvement in memory impairment and improvement in learning defects, improvement in liver fat, improvement in heart function, improvement in heart failure even. Their main side effects are GI side effects, nausea, vomiting, diarrhea, constipation. It's because they result in reduced gastric emptying. There was a big story about medullary thyroid cancer, and it is true that in mice and rats, it does that. And therefore, in people with a family history of medullary thyroid cancer or multiple endocrine neoplasia, we tend not to prescribe them. There is a low risk of pancreatitis, but it is there. And there is a risk of gallstones with anything that results in rapid weight loss, but particularly with GLP-1 agonists. Tachycardia and renal dysfunction have been associated mainly with dehydration and are reversible. Again, suicidal thoughts, although we don't tend to see this so often, except in those who lose quite a lot of weight quite quickly. There were safety concerns around cancers in general and thyroid cancer. There's an excellent review that was published last week on semaglutide and cancer, looking at a meta-analysis of 46,000 people. So odds ratio of pancreatic cancer, 0.2, reduced, but not statistically significant. Thyroid cancer, again, really no signal, and all neoplasm unity. So I think we can put that one to bed. We'll speak about the oldest and first one, liraglutide or Saxenda. The 3 milligram dose was the first one licensed for obesity. It's a GLP-1 receptor agonist with central and peripheral effects, which we discussed. It suppresses appetite and lowers gut mobility. And the mean weight loss was about 8%. Over 50% of people achieved the 5%, and about 30% achieved 10%. It is available in the UAE. It's less used now because it is a daily injection and tends to have more side effects than the weekly options. The whole program for the studies was called the SCALE studies. And in summary, we discussed this, about 3/4 of people achieved the 5% and about 1/3 achieved the 10%. The next one to come along was Ozempic or semaglutide, and the program here was called the STEP program, and we'll focus on step 1, which was purely for weight management. When this came in 2021, it was the first time that in the ADA, the whole hall went silent. Weight loss of 16% using a medication. This was approaching bariatric surgery. So 92% of people achieved the 5%, and 54% or 55% of people achieved 15%, and about 35% achieved 20% weight loss. They have a whole program, all of which is positive, as you can see the smiles on the right. Step 1 we spoke about, step 2 was in type 2 diabetes. Traditionally, people with diabetes lose less weight on anti-obesity medication than people who are non-diabetic, and this is no different. Maximizing weight loss, again, 16% versus 6%, and maintaining weight loss, so an additional weight loss of 8% in people who continued for 68 weeks. This is our own data. So in the UAE, semaglutide is used for type 2 diabetes. However, in people with obesity alone, it is self-funding, as insurance does not cover it. And at the time of doing this, it was off-label. It's now licensed, however, is not funded. So the mean dose, if you look at the bottom, the mean dose used, therefore, was low. It was 0.6 to 0.7 milligrams. The maximum dose available in the UAE is about 1 milligram. But even on that, at 6 months, there was 11 kilograms weight loss, or 11.5% weight loss, which was statistically significant. Of these, about a quarter had had previous bariatric surgery, and there was no difference between those who had bariatric surgery and didn't. They responded equally well. There are some anti-diabetic medications that cause weight loss. I'm not going to speak about the majority of them. We discussed metformin briefly. SGLT2 inhibitors cause glycosuria, and people lose the equivalent of a 2-stick Kit Kat in their urine every day, at approximately 5% weight loss. There are other GLP-1 agonists which are only licensed for diabetes, which we will not discuss, but we will speak about the interesting ones, including oral semaglutide and tirzepatide or Mounjaro, which is a combination of GLP-1 and GIP. GIP is another hormone produced by the gut. It's basically GLP-1's cousin. Side effects are the same, the effects are the same, but less than GLP-1. So oral semaglutide initially came out in doses of 3, 7, and 14 milligrams. And there was a whole pioneer program, 1 to 8. As you can see, the weight, although the diabetes effects are excellent, the weight loss was about 4% or 4 kilograms, and therefore really was not major. More recently, published last month in the Lancet, they have found a formulation, which is, let me take a step back. The way that they were able to give a peptide orally is that it was attached to what's called a SNAC, which is a sodium N-amino caprylate. And that basically attaches around the peptide, creates a higher pH or alkalizes the area around it to allow it to be absorbed. And that was the way it worked. But the absorption in the old oral semaglutide was only about 1%. They've now found a new technique. We're not quite sure what it is, but there's 30 to 40% absorption. And therefore the dosage has increased to about 25 and 50 milligram tablets. And the results are really exciting. They've got 2 programs, the Pioneer Plus, which is for patients with diabetes and obesity, and the Oasis 1, which is for patients with obesity. So let's look at the Pioneer Plus at the beginning. It has 1,000 patients, mean age 58, body mass index of 34, and HbA1c of 89%. there was a significant HbA1c drop, particularly with the 50 milligrams of 2%. And the effect on body weight was equally very good, with 8% body weight loss. And if you looked at patients who continued on the drug, as you can see on the right, then actually it was 9% body weight loss. This is the highest body weight loss we've ever seen with an oral tablet. OASIS was looking at people with obesity and not diabetes. As we said before, this group of people tend to lose more with anti-obesity medication. And sure enough, there was a 15% body weight loss with the oral medication, and 17.4 if you looked at those who completed on the therapy. So what they concluded was that once daily oral semaglutide is superior to placebo, was well tolerated with a safety profile similar to other GLP-1 agonists, and is an effective option for obesity management. Looking at the safety data, I'm sorry if the table is a little bit small, but just to show that there was really not a big signal at all for cancer. If you look at malignant cancers at the bottom, exactly the same between placebo and oral semaglutide. And if you look at benign and malignant, it was increased, but really nothing serious. I suspect it's because they were being tested more often. So well tolerated, good option. We move on to Mounjaro or tirzepatide. This has now been available for the best part of a year. It was licensed on the SURMOUNT trial, which was looking at 2,500 people with a mean BMI of 38 and no diabetes. And over 72 weeks, the weight loss was approaching 22% in those who continued therapy, or 20.9% on the highest dose. It's a novel glucose-lowering medication, which has both GIP and GLP-1. The side effects are very similar to GLP-1s. You start at a dose of 2.5 and increase by 2.5 every month, up to a maximum of 15 milligrams. SURMOUNT-2 was looking at people with diabetes. And again, the improvement in diabetes control was excellent, about 2.5% HbA1c, as well as a reduction in weight of about 16%, 15.7%, less than the 22% in those with obesity. So what does the future hold? The future is superbly exciting. Semaglutide, subcutaneous semaglutide, is being tested at a 7.2 milligram dose. At the moment, the maximum for obesity is 2.4 milligrams, and for diabetes is 2 milligrams. The results for diabetes sound really exciting, the Step-Up Diabetes study, but they are conducting studies for obesity. We spoke about the oral semaglutide. Our chair has asked me to mention the two in blue, so I will mention the two in blue, but just to tell you that they are not the only thing. There's lots more going on. For oral therapy of obesity, there are at least 2 other agents coming on. When we speak about orforglipirone, it will tell you what that group does. There are glucagon receptor agonists or triple therapists, triple agonists even, GLP-1, GIP, and glucagon. Interestingly, there is a GLP-1 agonist and a GIP antagonist, which is being tested for obesity. And PYY is a very interesting hormone that actually was pioneered by Professor Rachel Batteram, who has recently moved to Lilly, which makes me think that's probably something in the pipeline. I'll speak about the 2 that I promised to discuss. So orforglipirone, they've recently published their phase 2 trial on 270 patients with a mean age of 54 and a mean BMI of 38 with no diabetes. Over just 36 weeks, the weight loss was about 15%. This is a novel non-peptide, once daily oral GLP-1 receptor agonist. And the beauty of it being non-peptide is that, as opposed to semaglutide that one has to have on an empty stomach and wait for 30 to 50 minutes before you have a meal, this can be taken with food or with anything else. It's resulted not only in improvement in weight, but improvement in systolic blood pressure of about 10 millimeters of mercury, improvement in lipids, and this is all at just 36 weeks. And it does not appear to have plateaued, so we may watch this space, we may see even more. There's adverse side effects are very similar to placebo, which again is very reassuring. They used a few dose escalation formulae to see which one would work. And it seems that actually when you start with the 2 milligrams, you tend to do better, whether you then titrate up quickly or not. The side effects are very similar to other GLP-1 agonists, and they've just started a phase 3 program called the ATTAIN program. The other medication I was asked to mention was retatrutide. Both of these were submitted at the recent ADA, and they're published simultaneously at the New England Journal of Medicine towards the end of June. Again, this is a triple agonist, which has GLP-1, GIP, and glucagon, which is interesting. The weight loss here was 24%. If you looked at the group with weight loss of over 5%, once you got to the 3 higher doses or the 2 higher doses, 100% of people lost 5% of their weight. Half of people at the highest dose lost 25%, and a quarter of people lost more than 30% of their weight. So now this is not only bariatric surgery territory, but probably even better. Again, it's very interesting that the adverse effects were no different to placebo and not really affected by dosage. So very well tolerated. And the phase 3 trials are planned, the Triumph 1 to 4, including different classes of obesity with diabetes, cardiovascular disease, sleep apnea, osteoarthritis in different studies. Those who know me will know that I cannot have a talk without saying something about genetics. So this is my one slide. Personalization or individualization of treatment has got to be the way forward, whatever you're treating. We know that there are people who have monogenic obesity, so one gene causing their obesity. Most of these genes are in the brain and in a particular pathway, which has the leptin receptor, MC4R, all the common mutations. And in 2021, setmelanotide or Imkivri was developed and has been licensed, has been given a priority medicines designated by the EMA for treatment of obesity. So in patients who have mutations in any of these genes, we are able to offer them that. It's only the second medication to leptin. So I think now we've gone from really having nothing to having quite a few medications in people with obesity alone, the top row. So orlistat, Kesmia, lorcaserin, Contrave. The TICs are those that we can use in children with diabetes, liraglutide, semaglutide, tirzepatide. And again, tirzepatide is going to report on children in the next couple of years, and monogenic obesity, as well as all the newer agents we spoke about. What about combinations we use them for diabetes and high blood pressure? I guess the only problem is the cost. So for example, for tirzepatide, it's 1,700 dirhams and is about $1,500 in the US. To then tell the person that they need to pay for another medication with it, I think we'll be asking a lot. So in summary, good therapeutic options are available. And although each drug alone may not be ideal for every patient, there's an opportunity to try and test and see what works for them and whether a combination is necessary. For every drug, there's a group of individuals who will respond well above the average weight loss. And once you discover that, that is the treatment that they really need. So what does this mean for bariatric surgery? Then this is just my opinion. Bariatric surgery remains an essential tool in treating individuals, particularly those with advanced stages of obesity, where you haven't got time to suck it and see. Medical therapy is now showing similar weight loss to surgical therapy and provide individuals with a sound alternative. The initial concerns about long-term safety, at least for the older generation GLP-1, seem to be unfounded. The arrival of oral therapies might make it more acceptable to patients, particularly in this area of the world. Cost and a stable supply are an issue, and that's particularly been an issue with both semaglutide and tirzepatide this year. However, liraglutide has come off patent, and we are watching with interest. Let's see what cost it goes to. adjunctive therapy, either pre-surgery, as my colleague mentioned just before this session, to optimize health or to make the surgery safer, or post-surgery for weight regain seems sensible, but we do need to have formal studies. And even with all hands on decks, surgeons, bariatric physicians, dietitians, lifestyle coaches, psychologists, there is just not enough capacity in the system. So I think you'll be in a job as a surgeon for quite a while. But what I feel is that bariatric surgery may become targeted towards more advanced stages of obesity if medical therapy is readily available and affordable. So in conclusion, I'll remind you that obesity is a chronic, relapsing, multifactorial disease, that bariatric surgery remains the best option today. However, it's catching up very quickly. Historically, anti-obesity medications have been abject failure, but more recently, they've shown great success. Some can show significant weight loss and have a role in managing diabetes. Combination therapies and pharmacogenetics may have an added benefit if we knew beforehand what one would respond to. Managing obesity is a team sport. It's all about a multidisciplinary team. And that leads me nicely to thanking our team. We're honored to be working with two excellent surgeons, Dr. Mohammed Haddad and Dr. Khalid Hamdan. We are 9 bariatric physicians, including 1 pediatrician, Dr. Tawfiq, third down on the right, and 8 adult physicians. Dr. Matthew Allen, next to Dr. Haddad, is my partner in crime. And I'm happy to take any questions.
Sarah, thank you. Thank you very much. I can't thank you enough. Very interesting, very engaging discussion. I'll ask you a question, Sarah, if you don't mind, just to get this discussion going. Can you please tell us, since the introduction of all of these medications, how has that affected your day-to-day practice? Because as you've kindly mentioned, not before long, obesity management seems to be dominated mainly by surgery, being the most effective and well-known treatment. Now we've got other options. How has that affected your practice? Have you noticed a shift in your practice, a growth, a deviation away from surgery? I'd be grateful if you can shed more light on it.
Of course. So we're very lucky, yourself and I, we work in the UAE. And we have access to any medication pretty much as soon as it's FDA approved. And yes, we have, and also the disposable income is a little bit higher than other places in the world. So yes, we have seen patients opting for medical therapy, some unnecessarily, and they would not be prescribed the medication. It just doesn't happen in our center. Some actually have made the right choice, and we have seen people who have lost very significant amounts of weight. Often if you're paying for medication, you're someone who is driven. And that, I think, also skews our data. But yes, I mean, certainly semaglutide has had huge intake. We're currently looking at our data for tirzepatide. I believe we're one of the highest centers in the world for type 2 diabetes. We have over 4,000 patients on tirzepatide. So yes, it is a very interesting field. I think for the first time in a very long time, we're seeing the trend of both diabetic and non-diabetic people actually losing weight without bariatric surgery. Do we have a busy bariatric center? We have a very busy bariatric center, as you know. So we have, between the 2 surgeons, over 20 operations every week. It's not a quiet center by any means.
Okay, great. Right, I'll take this discussion globally. To start with, for all our audience, please do type in your question. I'll do my very best to go through them. I've already got a few really good questions for our speakers. So guys, be ready. You're on for a very heated discussion. Donna, we will start with you to share your experience about and to guide us within the Middle East region. I've recently been to the ASMBS and I could see the heavy presence of anti-obesity medication in pretty much all the discussions, all the sessions. As Sarah has said, medication has become part of the preoperative workup, the immediate postoperative management of obesity. What advice can you share to our audience in the Middle East? Is it something that you've got guidelines that you follow, or is it still a trial and error? I'll be very interested to hear your thoughts about this.
I think even before these newer medications, and I think that really started not in the last ADA meeting, but the one before that. It really marked a change in attitude about weight loss as a therapy for these chronic diseases, particularly type 2 diabetes. But even before then, there was a growing interest in the use of medications with bariatric surgery, using them sooner, using them more often. So I think all along, failures of bariatric surgery, when people regained most of their weight, medications were pulled in. But there had been a trend, a movement to start sooner, not let people gain all their weight back, but to start sooner. So I think that has been amplified. So that's one trend. The surgeons are embracing these medications. They're preoperatively, right, it makes their job easier when they go in, if the abdomen can be cleared of some fat. Earlier, post-operatively, I'd say certainly if patients have not had what the surgeons deem optimal weight loss, and we typically use these apps to track weight loss post-surgery. So by 6 months, if they aren't on track, we're bringing in those medications. We're not waiting. We're not waiting for weight regain. It's really sort of less than optimal weight loss. But the other thing that's going on, I think, is very interesting. And Sarah mentioned this, and she said that there was growing interest in the more severe cases of obesity. So, for example, at Pennington, Phil Shower is going to start a residential treatment center for BMIs of 60 and up. In the United States, we have a problem with skewing of the population distribution. 10% of Americans have a BMI of 40 or higher. 10%. And that's not just 40, it's 40, 50, 60, 70. So we have a serious problem here with individuals who have really severe obesity. And so I think our surgeons are going about trying to look at that in a more systematic way. So it's an exciting time, both medically and surgically.
Definitely. I mean, the table Dr. Sarah has kindly changed is an eye-opener. I thought there was about 3 or 4 being hidden, but looking at that table, it seems that the things are going to become quite interesting. I mean, from our point of view, I always say as surgeons, we are physicians, we're treating a disease. The more options I have, the more care I can provide to my patients. Right. Moving on to Dr. Iba. Dr. Iba, good evening. Thank you for joining us. I've got a question from a colleague by the name of Maria Yuma, and Maria is asking, do you have any experience in the use of anti-obesity medications or pharmacotherapy in individuals who have got obesity and type 1 diabetes?
Well, thank you so much, and it's my great pleasure to be with all of you here. We have published our data in obesity, and that's the use of the GLP-1 in type 1 diabetes. And I think what is important that we're calling for a change of guidelines, because currently no guidelines are addressing type 1 diabetes per se. And if you see, none of the, the industrial doesn't state that this is a contraindication to type 1 diabetes, but I think it's held by the physicians that they don't have the guidelines of type 1 diabetes. Do remember that we're treating the obesity in type 1 diabetes. So it's not the type 1 diabetes, we're actually treating obesity. And that's what we have shown in our retrospective data and in our publication in obesity, and actually conducted the first clinical trial. That is, we completed our recruitment that's looking for obesity treatment in type 1 diabetes, looking at all methodology, GLP-1s, SGLT2, a combination, intensive light treatment, and usual care. So it is safe to use the GLP-1 in type 1 diabetes. Do remember, when you use it, you have to use it at obesity medication dosages. You're not treating glycemia, you're treating the obesity disease. And there has been, some studies that looking at bariatric surgery in type 1 diabetes. It's a conflicting data that, there is definitely a decrease of weight loss. There is a definitely, decrease in insulin dosages, but the glycemia control has been conflicting in these data. But what we have been seeing in the type 1 diabetes, with the GLP-1, you do get some reduction in the glycemia, but it's more effectively is the weight loss that you do. So our type 1 diabetes are no longer lean people, and that's what we have studied in the medical school. We're seeing many type 1 diabetes with obesity, and we must offer them treatment. So we can't just, treat them that we have no option to them, but they have to be treated. So it is safe, but you have to, of course, there has been reported side effects, and that's what you have to discuss with your patients. And you have to make sure that these patients are highly educated, that they know that with decrease of their insulin dosages, that they should continue taking their insulin, they shouldn't stop their insulin, so they will not go at a higher risk of DKAs.
So Dr. Iba, please put your reference in the Q&A section.
I will.
You have a great paper on this. Yeah.
Agree. I mean, Iba, thank you very much. That's taught me something. My question to you, just to follow on, would you alter the insulin or the anti-diabetes medication dose that you use for individuals with type 1 diabetes, that you decide to use an anti-obesity medicine on for obesity, or do you keep them on the same dose?
Absolutely. So that's really important. For the GLP-1, you don't, so you will notice very little from the basal reduction. So, you would go mostly 10% basal reduction. But what you will see mainly is the prandial doses that will be affected. And that's when you teach people the carb counting, so they would know exactly what they need to take. And then you would stay on the carb counting per your meal. Their meal will be less, so their insulin dosages will be less. But that's why I would say you really have to have highly educated people. And, in Kuwait, we're lucky we have the Daphne program, where most of our type 1s are highly educated from the carb counting. That's why probably we were safe to use these medications, even, with the SGLT2 in people who have urinary microalbumins, and how to use them in the type 1 diabetes era. And that's also has been highlighted in our paper that's been published in Obesity. So, you don't need to do a marked reduction, but I would say 10% of your basal, that's from our experience. But the prandial insulin, that would be, the major defect. And don't reduce your basal insulin right from the beginning. Only when patients tolerate the higher dosages, then that's when you would need to decrease. And that's where I think the people start to get the glycemia, affecting differences. And today we're lucky in the type 1 diabetes that most people are either on, CGMs or on hybrid closed loop systems. And now we're looking at artificial intelligence and how we build these, because, with the closed loop systems, when people are on GLP-1 and SGLT2, and that is our next clinical trial, looking at mathematical modeling in these people with artificial intelligence in the type 1 diabetes era.
Amazing. Well, it sounds very exciting. Compared to our primitive surgery, I think the future looks very exciting. All right, moving on to Tahir. Tahir, the screen is on fire with questions, to be honest. I can't keep up with the questions coming. Tahir, I'll try to put a few questions into one for you, if you don't mind. I've got Amber Hussein, and she's talking about those that...
I'd like to take Poonam Shah's question, if that's okay.
All right, of course, please, go ahead.
So there's a question about post-surgery patients when to start GLP-1, and the nausea that gives disinterest. So I'll share with you a little bit of my experience with as a surgeon with GLP-1 medications. So first of all, I'm really glad that we have all these different medications that are now available for the treatment of obesity. I remember back in my training days, when patients would come back with weight regain or plateaus, the only thing we'd be hammering on them is, hey, control your diet, start exercise, control your diet, start exercise. We really didn't have much options back then. So having these medications available has really made our job much, much easier, because now we can actually address the biology that's behind their obesity. And that's where the last 2 decades of research have taught us how we look at obesity in a different way completely. Back then, we used to just say, hey, genetics is just a small portion of obese patients. Now we're saying it's the majority of everything. So it's truly biology that we're addressing. So when I counsel my patients, the thing I discuss with them is that we give them sort of, average weight loss goals that they can achieve with the different therapeutic options that they have. We ask them what exactly is their weight goal that they'd like to achieve, because at the end of the day, you will really want to achieve their satisfaction, right? Because if they don't meet their expectations, then they're going to be a dissatisfied patient. So you have to sort of meet the expectations, bring the expectations in the right place for both what is available as a treatment and what the patient has. So based on their expectations, and the majority come in with expectations of around 50, 60% weight loss, especially if their BMIs are 40 plus. So you try to explain to them that, hey, that's not just going to be possible with just surgery, because if you do a sleeve gastrectomy, you could probably on an average get 20 to 25% weight loss. With a gastric bypass, 30 to 35% body weight loss. So how do you actually reach your goal, which you want to be at a happy weight? That's where we can bring in medications as well. So sort of setting that stage up in the discussion beforehand, and then giving them the options of, starting up the medications before surgery to see how they feel with the medications before they embark upon it, and probably even giving them a little bit of weight loss before surgery. But then after surgery, I totally agree with Dr. Sarah. I mean, we use those different tools that we have. For instance, the ASMBS calculator that tells us how their weight loss should be based on that patient's customizations. And we see where they're falling according to their graph. And if we see that they're falling behind the curve, that's where we sort of start the medications. And patients who have a large target from before, we sort of start off their medications at around 2 or 3 months after surgery. So I typically, the ones that are available in Pakistan are the GLP-1 drugs, including both liraglutide as well as semaglutide. And we use both of these drugs based on the availability and the tolerance of the patient. I have seen a number of complications with these patients, I must say, and I'm sure all of you have seen patients with oral ulcers, ulcers in their legs, skin reactions that they develop. But by far, the majority of the patients basically have gastrointestinal sort of side effects that we can handle with a variety of different other medications. So that's my take. And I tell them that with these medications, you probably get around an 8 to 10% boost in your expected weight loss. Or if you are falling behind the curve, then you can sort of catch up with the curve. And I'll mention over here the Bari optimized trial that was just published like maybe a week ago from the group in NHS in London. And they've actually shown exactly the same thing. It's the first randomized control trial that looked at placebo versus GLP-1 in post-bariatric patients who've had less than 20% total body weight loss beyond a year after surgery. And they were randomized to either the placebo or to this for about, I believe it was 2 years. And they had approximately a 9% weight loss, additional body weight loss with the medication. So definitely there's a role of these medications in post-bariatrics, and we're going to be using them as well.
Definitely. I mean, I read the paper you were referring to, and I think the average was about 8.8% extra weight loss when they were using the pharmacotherapy following surgery. Right. Moving on to Bassem. Bassem, I've got lots of questions, and I would like you to share with me your experience with regard to the role of anti-obesity and how would it affect our practice as surgeons. How would you, assuming that you're going to stay to treat obesity as a surgeon, how would you incorporate these medications into your protocol with regard to your preoperative selection, postoperative, in combination to different therapies, be it endoscopic, surgical, or intragastric balloon? Can you share with us your insight? And if you are to put together, say, a guideline for your unit, how would you formulate it?
Yeah. The addition of pharmacotherapy, especially in the modern forms with the powerful effect, has really helped us quite a bit, and actually helped us push away eager patients, let's say with low BMI, who were pushing very hard to get surgery done. So now at least we have a reasonable, effective alternative that's pushing patients away from seeking surgery. And in particular, those are the patients with BMI between 30 and let's say 35. So we definitely encourage patients to pursue that route rather than proceed with surgery. Even now, endoscopic therapies, I'm really encouraging patients to pursue that, given the limitations of endoscopic therapy. And then what was mentioned earlier about the role of pharmacotherapy in helping us deal with weight regain after bariatric surgery. This is certainly something we welcome. I want to transmit some of the questions, if you don't mind, Hazem, to our colleague. And, we are now looking at this disease as we look at hypertension or dyslipidemia, potentially we're going to start the patients on therapy and God knows when we're going to stop them, right? So I'm going to transmit some of the questions by, let's say, Crystal Amaya. She's saying, like, what's the duration? I mean, is there a particular limitation? And then Dr. Shahzeen Waheed saying, we're going to expect a plateau at some point in time. What to do? And the question by Dr. Sanjeev Chetty is, what's the degree of compliance in your practice? Like, the same thing applies to hypertension, there's going to be a certain degree of compliance. Can you shed light on these three questions regarding long-term therapy?
Is that for me?
Donna's smiling.
Who were you
I'm getting a
addressing?
big kick out of this.
I could see.
Yes. So here's the answer. Show me the data. Show me the data. This, look, when you can't produce adequate weight loss, it doesn't matter. What's the importance of the question about stopping the medication? What's the importance about what's the best lifestyle to give? So having these medications that for the first time enable us to get robust weight loss, it opens up many, many questions, and we need data around these questions. Look, we have never studied weight loss maintenance adequately. We know what happens to the population on average. If we stop the medication, we're going to see weight regain. But I know within that population, there are subpopulations who are successful with weight loss maintenance. We need to examine weight loss maintenance much better and answer those questions about what's the best strategy for long-term weight loss maintenance. We need to answer the question, what should we do during this period of weight loss that sets patients up nutritionally for a maintenance period? What's the best diet? Barbara McGowan asked the best question about that in the chat box. The way patients got into this fix was in this highly processed diet. Maybe we should be using strategies during that weight loss period. There's so many great questions we need to ask and answer through research that these medications are making possible. Look, some patients don't need to lose 30%. They need to lose less. So what we've traditionally done is we've given our most powerful lifestyle, our most powerful approach to medications, a top dose. Maybe we don't need to do that for everybody. Maybe we need to be individualizing and personalizing our approach. We need research that shows us the path.
So, Donna, I'll bounce this back on you. Donna, you've been given funding and you'd like to design a trial or a study. Right now, where do you think the gap is? And what would you do?
I think the most important trial to do right now is a randomized trial between bariatric surgery, the most common one, sleeve gastrectomy, versus one of these modern medications. And the endpoints need to be not just weight loss, not just diabetes remission. They need to be economics. We know with our bariatric surgery that we start to see a return on investment within 3 years. Are we going to get that with these medications and their cost? What about body composition? Is the body composition with these medications that are affecting only appetite, is it equal across bariatric surgery versus these medications? There's so many questions that we need to answer with that randomized clinical trial. That would be my number one target.
And my
Sarah,
question,
what do you think?
And I fully agree. I fully agree. We do not have head-to-head studies and we definitely need them. What is nice is that even with retrospective studies, we can kind of get a feel. And to your second question, the sarcopenia, I think my gut feeling is it's not going to be very different with both of them if we cannot put in quite early on in the process of weight loss, muscle building exercises, ways to maintain bone health, then I think sarcopenia is inevitable with weight loss.
There's one thing that came out at the ADA, and Eric Ravison published his chamber study with tirzepatide, and tirzepatide increased fat oxidation. So the weight that was lost was, compared to semaglutide, there was a greater proportion of of fat
That's true.
loss compared to lean loss. And that's a good thing. So that GIP on adipose tissue, that target may be a meaningful one. There was no effect on metabolic adaptation though. So, I think the body composition data with tirzepatide looks a little better than the semaglutide. We need to keep pursuing that. Yeah.
And
One
Donna,
more comment just on the weight maintenance, sorry. I forgot to mention, and I think it's very important, with the newer GLP-1 agonist, which is the non-peptide, it actually works more on cyclic AMP rather than the arrestins. And therefore, what we normally see with GLP-1 agonists is after the first year or two, you then have weight maintenance or even weight regain. Whereas that with the newer one probably is not going to be an issue. So we're hoping it's going to be a straight line.
You didn't mention this, but if you have someone in your family who's on these peptide drugs, I'm telling you, it's bad for the environment, Sarah. You get this big box in the United States. All the prescriptions come by mail, and we get this giant styrofoam box. It's hard to recycle styrofoam. And, there are the cold packs and everything in there. So every 3 months you get this huge box that it's a hazard to the environment.
Can you not send it back? Can you not send it back to them?
No, they don't want it.
Tahir, you have a comment?
Yeah.
Sorry.
Right. So, correct me if I'm wrong, but till now, all the anti-obesity medications that we have are ones that reduce appetite or reduce hunger. And there are no medications that actually promote fat burning. But did you just mention that tirzepatide is a fat burner?
Yeah, so this is a study that was presented at ADA. I can send you the abstract of it to hear after this, and because it's publicly available. And the Eric Ravison did the study at Pennington, and he gave patients tirzepatide or placebo. He tried to match the weight loss. Of course, he didn't succeed because there was greater weight loss in the tirzepatide group. But he looked at in the metabolic chambers, the RQ can be measured there, and there's increased fat oxidation and elevation of the RQ. So that means that there's greater fat burning. There was no effect on metabolic adaptation. There was a reduction in metabolic rate overall with the reduction in body weight that occurred with tirzepatide. But this fat oxidation is a good thing, because if you look at the published body composition studies, about 25% of the weight that's lost on tirzepatide is lean. On semaglutide, it's about 40% of the weight that's lost is lean mass. So it seems to be that tirzepatide is preferentially promoting fat loss, which would be a good thing.
We know that bariatric surgery reduces. Bariatric surgery reduces hunger, increases metabolism, and has multiple ways of mechanisms by which it works. For instance, diabetes immediately goes away. The blood sugar control immediately goes away just without the weight loss. So we know that. But the current medications, they only work on one mechanism. So now we're seeing new drugs that are actually working on multiple mechanisms, just like bariatric surgery.
Well, these drugs, they're not just appetite drugs, as Sarah rightfully pointed out. They have effects on the kidneys, they're natriuretic, diuretic. They have effects on the heart and blood vessels. They are anti-inflammatory drugs. There's a study in dementia with semaglutide that's underway, for neuroinflammation. So they have an effect on appetite and weight, yes. They also have an effect on glycemia. They have other effects. So are they weight loss drugs? Are they diabetes drugs? Are they cardiovascular drugs? They're all of these things. So they do have pleiotropic effects. The retatrutide, we're going to be very interested in what's going on with that one, because, it's got the glucagon. And is that going to be the first one that actually increases metabolic rate or has an effect on metabolic adaptation? So now we've always been scared of glucagon because of its effect on glycemia, but let's see what happens with retatrutide. Exciting, huh?
It seems like this discussion can go on for hours. Dr.
Can I ask a question?
Yeah, definitely, Bassem.
Transmit the question, because this is a practical question that surgeons face all the time. We are using these medications quite frequently now and sometimes pre-op. So Dr. Vitaris and others have asked, when should we stop these medications pre-op?
Yeah.
Obviously they impair gastric
Emptying.
motility, they put patients at risk of aspiration. So when should we stop them pre-op?
I really can't remember the reference, Bassem. I was reading it literally a couple of weeks ago, and it was from an anesthesiology institute, and the recommendation is for at least a week because of risk of aspiration, because of, as you mentioned, one of the mechanisms of action of at least the GLP-1 groups of medication is reduced or slowed gastric emptying. So the recommendation is a minimum of a week prior to any elective surgery.
Do we,
they have such long half-lives.
Yeah.
Yeah, they're long acting.
I really can't remember the reference, but I'm confident, and I started quoting it for my to my colleagues.
Okay.
So I'm just going to ask a question to the panels, the voice. So you have changed the recent guidelines, and all your guidelines go to the lower BMI. So although we have the plethora of the medications, and I'm surprised these guidelines still come up recently when you have all the advent of the medication, that you're still focusing on the lower BMI. Would the data that today Sarah showed you, would this have an influence on you as a Ifso and others, metabolic surgery, of changing your guidelines and starting to focus back on the real role of the surgery, and where do you place it today?
So this is a question addressed for surgeons.
Yes.
Yeah,
the voice team.
Boys, put your gloves on. I asked you to take him off before the talk. Put your gloves on.
I think we want a point already.
I kind of answered that question first. In fact, we now encourage patients to pursue that route before committing to, essentially irreversible procedure. And then we'll see some patients because of economics will opt for surgery, some patients because of side effects. But we definitely have to give patients that option. And
in our defense, Dr. Iba, to start with, as I mentioned, we are physicians at the end of the day. We're treating a disease. We wouldn't have done what we've done today if we weren't excited for this, because as Bassem said, not everyone is suitable for surgery, and vice versa. Not everyone is suitable for medication. In the defense of Ifso, their guidelines were published prior to the publication of these outstanding results from anti-obesity medications. I'm sure this is something that will be taken into consideration. You can see the increased presence of these medications in our surgical meetings. And perhaps 2 years ago, I'd be criticized when I'm doing prescriptions for medications that everyone was telling me, you're a surgeon, why are you prescribing it? Now everyone is asking, what would you do? Looking at the questions here, the attendance, this is the most attended webinar by Ifso about medication. So as Bassem said, we believe in the drug. We're very happy that the drug is there. It's given us a lot of room to offer for our patients to treat their stubborn illness. Let's put it this way. Fahar?
Yeah, I totally agree. And that's something I mentioned, is that I'm really glad that we have these drugs available now as compared to the past where we didn't, and we really didn't have much options to offer our patients. But it all comes down to how to make sure that we give the right treatment option or options available to our patients according to their expectations. Today, I had a husband and wife, and one opted for surgery, the other opted for medications. So, I gave one medications, the other one I've scheduled for surgery. So that's how it is.
It is. Dr. Iba, I have a question for you. Now, in my humble experience with anti-obesity medication, I'm seeing patients coming for follow-up 3, 4, 5 months down the line, having started their medications, and they're returning to us with some nutritional deficiencies comparable to bariatric surgery. Do you have an approach with regard to preventing these complications when you start their treatment with regard to follow-up, vitamin supplements, routine blood checking, etc.?
Yeah, I think this is really interesting because, it's really well defined in the surgical world, but when it comes to the medical world, as none of the guidelines really put this forward. And I'm really grateful for you asking these questions. You know, with any programs that we put, probably for nutritional programs, when we have a marked weight loss, we would provide supplementations, but none of the, you know, of the guidelines for the obesity medications provide this today. So it's a time for us to change the way that we think forward. We know everything is really related to your nutritional intake and to your weight loss and the supplementation that is needed. Of course, you will not have to go to the similar mechanisms that we're doing for the bariatric surgery, because we know the absorption, you know, rates and things changes in the bariatric surgery. But it's a, you know, it's a point that where we need data for it. We need to make sure that we have the science behind it to give the people real advice about what supplementation and what we need to do. But it's lacking at the moment because none of the medications or the guidelines would support this at the moment. So it's an area that definitely need to focus on. So thank you so much for asking the question.
Right. Bassem, I believe you've got a question to us,
Yes.
please.
So the clinical trials are really focused on patients, let's say, with BMIs from 27 to 14. We have now robust data. Can we translate these to higher BMIs, this data, to BMIs of over 40? And for example, we have a question from Dr. Muhammad Islam for very high BMI patients, combination treatment with drugs and surgery. Which one is having better long-term? Surgery first, then drugs, or vice versa?
I don't think there's enough evidence out there to answer this question, Bassem. If I'm to compare what we used to do with regards, for example, with the intragastric balloon preoperatively for individuals with severe obesity and very high BMI, I think the use of pharmacotherapy to lower the BMI and to make the surgery safer is an option. Obviously, to stop it preoperatively. Now we have enough evidence to suggest that we can safely start these medications within 6 months of surgery and to achieve even continuous weight loss. And I think if we are to copy that example, that would be my approach with regard to the use of anti-obesity medication in individuals with very high BMIs over 60, for example.
Great.
And the way that I would take it, treat the disease aggressively, don't treat the weight. So forget about the BMI. If you know, it's the aggressiveness of the disease. So if it's aggressive disease, you would need to use all your tools, similar to what we use in cancer therapy. You know, if you're just a number, then, you know, we don't need to go for the most aggressive. So treat the disease rather than the weight.
Well said. Tahir, as I said, the screen is on fire with questions. If you are to choose a couple of questions, please help yourself.
Yeah, I think there are a couple of questions about which are the right medications to choose. So the thing is that, again, as our speakers and panels have mentioned, is that we need to have a multidisciplinary team approach. And so it's important to look at the patient completely and tailor things according to their needs. Like, for instance, if somebody is diabetic, and so in combination with my endocrinologist, we sort of start off a combination of SGL2 with metformin medications, and then probably start adding a GLP-1 medication, especially if their diabetes has been uncontrolled. Somebody who's got uncontrolled diabetes with, you know, super morbid obesity with BMI higher than 50, that's where you want to make sure that, you know, the other aspects of their health are also being addressed, their blood pressure, their diabetes, their edema, pulmonary hypertension, and so on and so forth. With regards to just weight loss medications, and if you're trying to choose between the GLP-1 medications, I would suggest is that you see what are available to your patients cost-wise, as well as availability, because sometimes there are supply issues. You can try, give them the options of weekly versus daily. Some, you know, tolerate one versus the other. And again, just like diabetes is a complex disease that you start one medication and then you see the patient's response, and sometimes it doesn't work out and you have to change it to a different medication. It's the same thing over here, because obesity is a complex chronic disease, and you have to sort of see which one, which is the right fit for your patient.
Right, Bassem and Tahir, just be prepared. Sarah has asked to ask a question to the other girls, so I'm not sure what they're up to. Sarah, I think you have a question to Donna and Iba. Please go ahead.
Yes, it's more along research needed. We're speaking about pre and post bariatric anti-obesity medications. So the beauty of the newer ones is that they're oral.
Yeah.
how are we going to manage that with Roux-en-Y's?
Yeah. Yeah. Good
That's a
point.
question for you.
Good point. Yeah. Well,
That's
we're
a
gonna-
curveball.
we're
That's
going
a
to give them the
curveball, brother.
injections.
I guess.
Yeah.
That's a
No, we're not
curveball,
going to
brother.
we're not going to do the Roux-en-Y with the
All right.
oral medications.
Done. We're not going to do
Yeah,
that.
not a good idea. Thank you,
Yeah.
Sarah.
That's a very good. It's a very good
Excellent.
question. And I
Excellent
think
question. Excellent.
it's an amazing question, actually, and especially nowadays, because we now know there is no lifelong surgery, and any patient will regain a bit of weight at one stage in their life. And yeah, I think the bypass, the one anastomosis. Now we've got the SADI coming on the screen, so it's interesting. Dr. Iba, how would you answer Dr. Sarah's question? If you are with regard to research and the use of orals post malabsorptive procedures?
Well, I think, it would be very difficult with the Roux-en-Y gastric bypass. And we have seen it with many medications. That's, so it would be impossible to use the oral. So your only option would be the subcutaneous injections. So, but yeah, so it's probably one of the discussion points that you have to hold for the future with your patients. So, if weight regain happens, then you won't have the options of the orals and you have to be on injectable therapy.
Yeah, I've got a comment from Barbara, and this talks about it takes 2 months for semaglutide to be completely washed out, and this is why the manufacturer advises or recommends to avoid pregnancy during that time. I fully agree with that comment. However, with regard to the surgery, elective surgery, I mean, the 2 months rule would not apply, I think. And one of I think Lee Kaplan had shared the link to the recommendation from the Anesthesia Society. Thank you very much. It's within the questions, guys. Okay, I have a question as well about, and this is for you, Sarah. Have you got some sort of an algorithm? Not long ago, I attended to one of the talks from Mayo Clinic, and they were talking about their approach with regard to the choice of anti-obesity medications. They talk about brain hunger, gastric hunger. To be honest, it's beyond my understanding as a surgeon. It was too complicated for me to understand. But they seem to have quite a nice algorithm with regard to the choice of anti-obesity medications. With regard to our audience, I do strongly advise you to read that paper. I'll share it with you shortly. It's an amazing publication. Sarah, do you have a similar approach with regard to the choice of medication, assuming the availability and the ability of the patient to afford these medications?
I'm going to be extremely naughty. Thank you, Hazem. I'll pay you later. But this is a great plug for the UAE Obesity Conference, which is on the first weekend of November. And the whole conference is called What Can We Do Better? And one of the talks is oral medication. What can we do better? How can we personalize it? How can we individualize it so that people who have problems with satiety, i.e. they eat and eat and eat and eat and never get full, can have maybe contrave. People who have problems with feeling hungry a lot quicker can maybe have a GLP-1 agonist. And Marga El-Sheikh is an excellent speaker. She will be speaking on that.
But we need a teaser. Come on, Sarah. We need the teaser.
I've just given you a teaser. You have to come. Yeah. So there are. It's, as I said before, I'm fully bought on personalized medicine. I believe that there are horses for courses. There are people who will lose 40, 50 kilograms on a GLP-1, and there are people who will lose. So everyone is made different. Sometimes it's suck it and see, but sometimes if you listen to the patient, they will actually give you a very good description of their disease. It is a disease. It is
Definitely.
a disease. People are different. Some people are hungry all the time. The other plug I'd like to say is for any child who gets obesity below the age of 3. If they're hungry when they're breastfeeding and their mum can't cope, if there's it is likely to be genetic. Please do look at them. Please do refer them because they're the ones who will have bariatric surgery. They will have revision. They will have medication, and they will be in the same position.
Yeah.
So
definitely. Well, Sarah, we measure what we know. We know the GLP-1, we know the leptin, we know the glucagon, but there are definitely other pathways that we still don't know. So I fully agree. Now, I've got another interesting question or comment from Barbara saying that these medications are becoming quite potent. Does that mean we don't need to exercise? And watch what we eat anymore? Will it be a quick fix? So I've got a holiday coming or an occasion, I need to lose weight. I go to the chemist or pharmacy and inject myself or take a couple of pills. Do you think that's the way forward?
So I'm happy to take that, because in the UAE, we already have that, Barbara. We already have the BMI 20 going to get tirzepatide because she can afford it. And it's a disaster. It's my friend's wedding. I need to fit into a size 4 dress. I'm going to do that. Do they still work? Yes, they still work. Is that the right thing to do? No, it isn't. The other side of the coin, which I believe is going to be the story of the future, and I certainly hope so, is we have people who have suffered with obesity for 10, 15, 30 years, who have done really well with the GLP-1 agonist. They've achieved a weight that they are happy with and that we are happy with, because medically they are no longer diabetic, their blood pressure is well controlled, and they are happy to have a holiday. They're happy to have a holiday for 3 months, 6 months, and when they feel that their weight is returning, they will come back and say, do you know what, I think I need to restart again. And I do feel that in itself is a success story, that they're able, with exercise, with managing their diet better, because GLP-1s work in the brain and they help food choice. We have a very traditional food in the Middle East called kunafa, which is just, it's stodge, it's sugar and fat, and it is just lovely, but a disaster. And if you give a person kunafa,
it's nice, it's not a disaster.
And if you give them an apple,
I have to defend kunafa.
Yeah, if you give a person kunafa and you give them an apple, myself included, everyone will take a kunafa, except those on GLP-1s. They will take the apple every single day.
Agree. And I've seen it with very close friends. Agree, 100%. Right. Can we just touch about the safety? There are plenty of questions about the safety with regard to the indications, contraindications, the pregnancy. I think, Bassem, you've made a comment about the presence of gallstones. We've already made the comment about anti-obesity and pregnancy. 2 months, the recommendation from the manufacturer. Bassem, I come to you. I want to be started on a GLP-1 analog, and I'm known to have asymptomatic gallstones for several years. What would you do?
Yeah, or else one of the questions also is, do you check for gallstones before you start therapy? And let's say you find asymptomatic gallstones. Is that a contraindication to starting therapy or not? Knowing that the patient is diabetic, obese, has sleep apnea, has fatty liver, which takes precedence? I personally would start and would tell the patient that there is a risk, just like in bariatric surgery. Many times we leave gallstones behind, and we tell them, as I prioritize, I think it's better to start losing weight and getting rid of your medical problems. If cholecystitis would develop, that we can manage that. That's my approach, at least. I don't know.
I share the same approach to you, Bassem. Asymptomatic gallstones is not an indication for surgery. We know around 70% of gallstones are asymptomatic. Any medication or treatment, as Sarah has mentioned in a talk, that causes rapid weight loss can predispose to gallstones. Unless there are symptoms, I don't offer elective laparoscopic cholecystectomy. I don't offer elective ultrasound prior to starting anti-obesity medications. Tahir?
Yeah, I agree with you exactly. I mean, it's the same thing with bariatric surgeries, that we only offer the gallbladders. We only offer to remove the gallbladders if they're symptomatic. But I do have a question and a comment about the safety, which I'd like to ask Dr. Suleiman, is that if somebody does have a history of some sort of gastrointestinal cancer or pancreatic cancer in the past, what is your approach for those kind of medications, knowing the history of how exenatide actually came around?
So that's an excellent question. I think, so the only example I actually have is a patient who has a carcinoid, not a benign carcinoid, a malignant recurrent carcinoid that I have. However, his BMI is 42, he is diabetic, he has high blood pressure, and he is extremely educated. He's a lawyer and he's extremely educated. And we sat down and had a discussion. He is far more likely to die of a heart attack than he is of his carcinoid, which he's followed up for. He's had surgery in the UK 2 or 3 times at Imperial. And we've decided that he will start a GLP-1 agonist. He's on tirzepatide. He will continue on it. We will stop it 6 weeks every year to try and get his hormone levels without a GLP-1 affecting that. And we've been doing that for a couple of years now. He's very happy. I'm very happy. He's lost about maybe almost 20 kilograms in weight. His diabetes is far better controlled. He is an N of 1. And that takes me back to personalized medicine. He cannot make the rule. He is someone who is extremely bright, who joined in that discussion. Would I give it to someone who was unable to take that information in? Absolutely not. Not because I believe that there is an increased rate of cancer. I believe, in my own opinion, that obesity increases the risk of cancer far more than a GLP-1, certainly by the evidence we've seen so far. There will be MEN1, MTCs are the exception, but as a general rule for other cancers, I would feel pancreatic cancer is a bit, I would sit on the wall, although the current data with almost 50,000 people suggests that actually there's a reduced risk of pancreatic cancer in people with GLP-1 agonists. We just have to treat, until there is evidence, going back to what Donna says, we will just have to treat every single patient on his own.
Because I believe like the first trial actually with the medications actually had 6 patients who developed pancreatic cancer, right?
Correct. So that was with the exenatide, the short-acting exenatide many years ago. I think that was then re-looked at with long-acting exenatide, and there was no evidence found for pancreatic cancer. It's always been in the background. It's been looked at. It's still a black box for exenatide. But actually, it's come off the black box, hasn't it, on the FDA? Is that right, Donna?
Well, you know, all the drugs in the class in the US under the FDA have a black box warning about not to use it in patients who have medullary thyroid cancer. And then they also indicate the risk of pancreatitis. But no, there is no pancreatic cancer warning in the black box. I want to change the subject a little bit, if I may. And that
can I just make one quick comment on it? Because we've had a few questions about when should these medications be stopped prior to surgery. And I've got it on my screen now. It was the American Society for Anesthesiologists, and they talk about hold GLP-1 agonists on the day of the procedure for patients who take daily medications. So we're talking about liraglutide. And then hold GLP-1 agonist a week prior to the procedure or surgery for patients who take medications weekly. So we're talking about tirzepatide or semaglutide. It is the American Society of Anesthesiologists. Back to you, Donna.
Yeah, so this is about frailty. And, you know, we are more careful about weight loss in older individuals. And that is because of the endocrine involution and the loss of muscle mass with aging. So in the Look Ahead study, you know, that study just produced modest weight loss, but the people in Look Ahead were followed for more than 10 years, and they had many wonderful benefits of that modest weight loss, but they did have an increased risk of frailty fractures. And so even modest weight loss is associated with that. You know, one thing that I think the surgeons have done that we need to emulate on the medical side is that patients did not get surgery without multidisciplinary care. They saw a nutritionist. They were given counseling on diet and physical activity post-operatively. And we need to be doing that too. So I think that, you know, the danger of these medications is that anybody who's licensed to prescribe can prescribe them. And, you know, and I think patients need to use these medications if they do need to lose weight for health reasons. It's a window of opportunity to improve nutritional status, to improve their physical activity patterns. So to me, I hope we'll emulate the surgeons in that we use the medications not just as tools to work through appetite so that patients can lose weight, but to get patients to a better sort of lifestyle approach.
Right. I have I have a question from our dear colleague, Dr. Ahmed Bashir. Dr. Ahmed Bashir is amongst the well-known surgeons within the region and globally. Dr. Ahmed, I think he's a bit disheartened by our excitement as surgeon for these anti-obesity medications when we compare the lack of excitement from non-surgical colleagues to the surgery that we've done for many years with established track records and long-term results. I have my own insight with regard to the answer to this question, but I'm interested to hear from the colleagues. From my side, Ahmed, the way I see it is, I think for quite a number of years, the treatment of obesity has been the main interest and occupation of bariatric surgeons. And this is why we're the one who are watching it on a day-to-day basis. And we're the one who are very excited because it is our bread and butter. These new medications have offering quite impressive results compared to what we offer as well. I agree, we do not have long-term results, but I think the future looks bright. These new medications will make the disease more interesting to other specialties and other colleagues, family physicians, endocrinologists, general practitioners will come on board in the treatment of this disease. And this is my explanation. We've been always fighting this battle on our own. Now the army is getting bigger and bigger, and we've got more people on our side in the treatment of this disease. This is my insight with regard to this. With regard to anti-obesity and lactation, I believe none of them are recommended to be used in breastfeeding women. And I'd like to hear your insight, guys.
I'll say one last thing, and that is that, you know, I'm reading in the Q&A that we're not really emphasizing the weight regain that can occur with stopping these medications. Yes, if you stop your blood pressure medicine, your blood pressure is going to get out of control. And the same thing is likely to happen here. So when we stop the medications in a blinded fashion, the weight regain, we can track it up. You know, your best chances of keeping the weight off are to stay on the medication. Most patients want to stop medications, and Sarah alluded to that. So our strategy for that is if they stop, we monitor. If they regain weight, we start again.
Bassem?
To answer Ahmed Bashir's question, or
Yeah, if you don't mind, I don't mind, because Ahmed
Yeah,
has got a very, very valid point.
yeah, I don't think our colleagues are not sharing our enthusiasm for surgery, but it's like you mentioned, you know, suddenly we have medications that are powerful enough to at least use in practicals. Before, the medications were really not practical at all. So I think they're more showing enthusiasm for this new drug rather than a kind of a disappointment with surgery. That's how I look at it as well.
Tahir, thank you, Bassem.
So thank you. So the way I look at it is that, you know, because this disease is a complex disease and it has multiple mechanisms behind it. So sometimes one treatment doesn't always address all the mechanisms behind the disease. Like, for instance, we know that like many bariatric patients don't lose the amount of weight that we're expecting them or hoping that they would lose. And sometimes they have regain as well. So it is because there is aspects of the biology that were probably not addressed with the surgery. And so those patients, were failing on those patients by just providing them one treatment option. So by giving them these multiple treatment options, we can address the different facets of the disease and make sure that we help them, you know, lose the weight that they need to lose.
I want to say something bad about the medications. Okay, in a way, even in the United States, yeah, these medications, they're like a mirage. It's like you're in the desert and you see the beautiful oasis and it's not really there. And the reason for that is our payers, our third-party payers, are not covering these medications. And the patients who need it the most, the patients who are at most risk for the health effects of obesity, tend to be the ones who have more adverse social determinants of health. And those patients do not have access to these medications because they can't afford them. In the United States, it's $1,300 a month for semaglutide. It's out of reach. It's out of reach for even the middle class.
Can I mention something, Donna? It's interesting you say what you've said. Just last week, I was We were talking to the reps of one of the medications we use, and we're struggling to provide it to our patients. And what they told me, the sales of this medicine in 1 month in the US is equal to the sale of the same medicine in the United Arab Emirates in 3 years.
Yes. Yeah, the United States we're used to carrying everybody else in the world by the cost of our medications. It's crazy over here, guys. I cannot defend this. There are not 50 people in the United States who understand the system by which medications cost so much. We have so many pharmacy benefit managers. We have so many insurance companies. We have the drug makers themselves, and everybody points the finger at the other guy as being responsible for the high cost. We don't even know what they cost, actually, but the list prices are that if you want to just go and buy it, they're ridiculously out of sight. Everybody's getting a discount here, there, and yon. But I will tell you this, 50% of the sales of these medications in terms of monetary are from the United States of America. We do not have 50% of the obese people in the world. Why are we paying? Why are we subsidizing you guys? I mean, I love you, but.
All right.
And
Right.
as a confirmation, sorry, can I just come back on that?
Yeah, please help me.
So we are in a similar boat to you. Semaglutide in the UAE costs 1,200 dirhams, and in Kuwait or Saudi Arabia, 300. I'm going to start a bootleg program to go and buy semaglutide when it's available and sell it here. But I hear you. And I think it's all about negotiations. It's all about getting people who can make a difference on board.
So it's Sarah, you and Iba and I know that our surgeons join us in this. We see the opportunity of these medications that produce robust weight loss and have all of these other benefits beyond just weight loss. We see this as an opportunity to help patients who have all of the chronic diseases that are filling our clinics. And it's so frustrating not to be able to access these medications. We've got to do better.
Right. Listen,
what do you think is going to happen? Sorry, Hazem, one more. What do you think is going to happen with liraglutide now that it's come off patent? Do you think every uncle is going to produce it? Or are they going to block them?
I hope so. I think it will depend on these big global generic manufacturers like Sun from India. We'll have to see what they do. There are challenges to producing those peptides. They are not inexpensive to produce, and they require that cold chain. So for something like liraglutide that has to be given every day, it's got a lot of extra cost besides just the cost of the drug to deliver it to people. We'll have to see. It's not cheap.
I'm really, really sorry. We do need to bring the discussion to an end. I can promise you we can be here all day. Now, let's wrap things up. I'll go around my screen in no particular order to ask for your final remarks. I'll start with you, Tahir, please, because I believe you've got a commitment somewhere else. I'm really grateful for your time with us and participation, Tahir. Thank you very much. Any final comments?
I think it was a wonderful discussion, and it's probably opened up a lot of opportunity to do a lot of thinking and research on various aspects that we still don't know, such as weight maintenance and long-term effects of these medications. But I think it was overall, all in all, a great discussion that we've all had. It'll hopefully help both surgeons and obesity physicians collaborate even further to improve the care of these patients.
Thank you very much, Tahir. Dr. Iba, final remarks, final comments?
I think we really need to look into the guidelines today and update our guidelines. People with type 1 diabetes, people with lower BMI, people on maintenance therapy, people for nutritional support for these medications. So there's a lot of questions that still need to be answered, and we need to keep updating our guidelines and look into really multidisciplinary theme together in whatever we do, using all the tools today. And do remember that we're treating a disease, not a lifestyle, an image today.
It's not a choice. Agree. Bassem, final comments?
Yeah, I have a comment, actually, a message to young bariatric surgeons. Don't be alarmed. Don't be afraid. The future is bright. Get involved in bariatric medicine, just like Dr. Tahir did and others have done. Okay, treat the disease. Remember what Dr. Sarah said, we're operating on a fraction, a very, very, very small fractions of potential patients. Those medications, if anything, are going to increase your pool of patients who will come for care, will be satisfied with weight loss, and they would want alternatives when they regain weight after medications. So the future is bright.
Donna?
Yeah, so I think what this webinar has once again illustrated is the incredible talent that's coming from the Middle East. You guys keep it up, keep publishing, keep making guidelines, do more, and I'll see you in November.
Is that a date or a threat, Donna?
Both. It's both.
Oh, all right.
So, thank you so much for including me.
Donna, thank you very much. Dr. Zara, final comments. I kept you last, but for no other reason other than you've been the star of the show today. Please, Dr. Zara, any final comments?
Thank you very much for the invitation, Hazem. I thoroughly enjoyed it. I enjoyed the discussion. I should say that both Dr. Iba and Donna Ryan are going to be speakers in November. But also, just to say to your colleague, Ahmed Bashir, we are, and I can speak for the three of us, I don't know about other physicians, probably more of bariatric surgeons than the bariatric surgeons. Where we see that someone needs bariatric surgery, we would be the first to actually recommend and support people through that process. Don't worry, we are a team, we work together. You'll be in business for a very long time, but
Definitely.
hopefully there will be options.
Definitely. I'll tell you what, guys, I mean, I don't know where to start. Iba, I mean, your contribution has been outstanding. You're a hidden gem. I'm really regretting not to have known you before. Thank you. Thank you very much for your contribution, for your scientific input, for your approach. Tahir and Bassem, my comments about you are biased by any way, shape, way, or form. Thank you very much. Donna, you've been a great addition. You've been a huge advocate to our local talent, as you've mentioned. Thank you very much for your belief in them and in our support. Sarah, it's been a real pleasure. I really thank you. For everyone listening to us, Sarah just flew back from the UK today. She's half asleep, and look at her. Imagine her in firing in all 6 cylinders. For all our listeners, our audience, keep the discussion going on our social media. There'll be a recording of this meeting on our Ifso Virtual Academy, on our YouTube channel. You can post your questions on our social media platform. Twitter is very active for us, such as Facebook. For those of you still using Facebook, we can pass your questions to our panelist and speaker. Thank you. Thank you very much. I can't thank you enough. I can't stop. Thank you very much. Enjoy your day.
Thank you, Hazem.
Thanks everyone.
Thank you
very
very
much.
much.
This was fun. Okay.
It was huge fun. I don't want it to stop, but everyone needs to be somewhere else.
It was
Thank
great.
you.
Sarah, that is the best talk. You did it again. You're incredible. Bravo.
Thank
Bravo,
you.
bravo,
Absolute
bravo.
pleasure
I'm
having
stealing
you.
your slides. I want your slides.
Of course, of course.
No, they're owned by Ifso now. No. Bye-bye. Bye-bye, guys.
Bye, guys.
Bye-bye.
Have a lovely evening.